I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Gail Wilensky, an economist and senior fellow at Project Hope, who directed the Medicare and Medicaid programs from 1990 to 1992. Dr. Wilensky has written a perspective article on possible directions for bipartisan Medicare reform. Dr. Wilensky, you outline a few major areas of overlap between at least some Democrats and some Republicans, such as raising the eligibility age for Medicare to 67, tying benefits to income level, limiting spending growth to the gross domestic product plus 1%, reforming healthcare delivery, and moving away from fee-for-service payment. How solid and how big are these areas of potential agreement?
The question about how solid the agreement is harder to tell. What I've noticed is that both Republicans and Democrats have included many or all of these components in some of their proposals. And it's that overlap that led me to identify these as major areas of agreement between at least some of the Democrats and some of the Republicans who are proposing Medicare reform. So each of these elements can be seen and therefore at least represents a position of acceptance by some leaning proponents in their parties, but certainly not by all individuals.
And if all these changes were implemented, how big a difference would it make?
Well, there's really two pieces to that. The first is that if all of them were implemented, that would have a significant effect. But some of them are much more important than others. The increasing the eligibility age to 67 and tying benefits to income level are somewhat smaller, although the income level, depending on how you income relate, the benefits may not be so small. There's no question that limiting spending growth to the GDP plus 1%, reforming how care is delivered, and moving away from fee-for-service could have huge effects on Medicare spending.
Speaking of limiting growth to GDP plus 1%, what are the possible mechanisms to do that? And is there agreement on any of those possible mechanisms?
The major ways that people have talked about limiting the spending is either through a mechanism of direct price controls on the services provided under Medicare. That's using the so-called Independent Payment Advisory Board that's part of the Affordable Care Act and that the President has referenced. That is one strategy. And a second strategy involves using premium support, which has been now proposed both by Congressman Ryan and Senator Wyden in terms of their joint efforts, but earlier by well-known Democrats such as Alice Rivlin and other individuals. And in that case, the limit on spending occurs as a result of how you set the subsidies.
Reforming the delivery of care is probably the most abstract of the concepts that you raise. Do the parties agree on what kinds of reforms are desirable in care delivery?
It depends how high a level of discussion you begin to have in terms of how much agreement there is. Most knowledgeable people agree that the incentives currently embedded in healthcare in general, but particularly in Medicare, are not helpful. Reimbursement rewards doing more and more complex procedures rather than improving a patient's health and health outcomes. There's no reward provided for higher quality, and there's certainly no reward provided for efficiency. So there is widespread agreement that we need to change the incentives that are involved, and we also need to encourage more care coordination, both because the patients on Medicare frequently are experiencing chronic diseases, sometimes complex chronic diseases, and we need to find a way to encourage that kind of care coordination as well as reward the kind of behavior we would like to see result from the care that is delivered. The rub is how exactly do we get there, and operationally, what does it mean to change those incentives? That kind of specificity does not produce widespread agreement, but there is surprising agreement about the difficulties of the current incentive system that we use in Medicare and the urgent need to change those incentives so that we encourage the kind of behavior we'd like to see.
Broadly speaking, the kinds of areas of agreement you're talking about would lead to compromises between the parties. Historically, has Medicare been an area where parties did compromise? Have they been willing to compromise?
Well, painfully not in recent history, or at least not very often in recent history. And, of course, we are currently in that most partisan of periods that we experience every 4 years at least with a presidential election and the by-year elections as well. But even during some of our recent partisan periods, we have been able to achieve some agreement about changes to be made in Medicare. The kinds of changes that I'm describing, however, would require a lot more bipartisanship than we have seen recently. My assumption is as the financial pressures continue to grow as a result of the retirement of the baby boomers, it will push members of Congress and the Congress with the administration to look for ways that they can agree on to fix this program. If not right after the election, then within the next 3 or 4 years, because the pressure that will come from the continuing retirement of the 78 million baby boomers is going to produce incredible amount of stress on the system.
You mentioned the Ryan Wyden proposal, which is, of course, a bipartisan effort. Is it, in your mind, viable?
I like it very much in terms of the general outline that these two members of Congress have proposed. I'm a believer in premium support as a mechanism to try to help both introduce innovations and to encourage new delivery systems as well as to involve seniors in some of the decisions that go on. There are a lot of specifics that have not yet been specified in the Wyden-Ryan proposal, and that's, of course, only to be expected given the stage that it's in. It was, to me, promising, encouraging that even during this current election period, there was a willingness by a Republican and a Democrat to make this rather bold proposal and to make it jointly.
Do you think it can get broad bipartisan support?
Well, we won't know because it's certainly not going to get broad bipartisan support before the election. They recognize that as well. It will depend in part on the kind of message that the public sends after the November election. We'll see what that new Congress looks like. It is disturbing to me the longer we have our election cycles, the more partisan the rhetoric seems to get. And that makes coming together after the election even harder than it might otherwise be. But that is, at least right now, the nature of our political process.
You note in your article that Medicare spending, like all health care spending, is currently growing unusually slowly, partly because of the recession, of course. In another perspective article, White and Ginsburg argue that this slowdown is actually not a fluke, given ongoing cuts to reimbursement rates and the provisions of the ACA that are related to payment reform. Do you buy that argument? Are you encouraged by it?
I think it's way too early to make that judgment. There is no question that if the reductions in payment that are embedded in the legislation are actually all implemented over the course of the decade, it will slow down spending substantially. Although once you include the retirement of the baby boomers, the actual aggregate growth in Medicare spending on a yearly basis will still be quite substantial, 6.6%. But the actuary has raised some concerns about whether or not the kind of reductions in payment that were included in the Affordable Care Act can be implemented without causing significant impairments to access. The actuaries also, in a recent article, commented that the slowdown is greater than had been expected, and he's not sure why exactly it's occurring, and as a result, is reticent about predicting that it will continue in the future. So it looks a bit promising now. It's nice to have some positive news, but I think it's way, way too early to assume that we have turned some corner and that it is going to be better going forward for some undefined period of time. We'll see in another 2 or 3 years. After all, this is early 2012. The implementation of the Affordable Care Act is really just in its early phases.
Turning to another aspect of the Act, in a third perspective article, Cutler and Gauche look at two different approaches to payment reform: bundling payments by episodes of care, bundling payments by patients. And they conclude that the episode-based bundling might save slightly less money, but it would also encourage efficiency in treating conditions on which spending is high, regardless of whether it's in a high-spending or a low-spending region of the country. Do you see that as a promising approach?
It's an interesting issue that they have raised, not without its own challenges as well. It is certainly far better than what we do now, which particularly for physicians is to reimburse physicians on the most micro of units, the $7,000 or $8,000 codes that are part of the CPT codes. So going to a bundle payment is a vast improvement. As they indicate, it does raise a question about whether or not you might have some concern about volume of episodes that would result if you move to an episode-based payment that you don't have if you actually pay an amount per person. But you have to be careful on the amount per person. You want to be sure you don't have incentives to skimp. And it has led some people to suggest the best of all might be neither a purely capitated system nor an episode-based payment, but to have a blend between fee-for-service and a capitated system. Having said that, the episode-based payment is way better than what we have now, and so part of it will depend on what looks like it can be implemented relatively easily and what can be sold politically. Both capitation or episode-based payments are vastly better than what we've got now.
Finally, we have two perspective articles on the Medicare Advantage program and the lessons that it might offer for Medicare reform. How do you rate Medicare Advantage as a market-based solution for Medicare? Are there important lessons that we can take from it?
The most important is that if you put as many constraints on a program as you do on the Medicare Advantage program, we shouldn't be surprised if the outcomes aren't exactly what we had in mind. There are many problems with the current Medicare Advantage program. Most importantly, it's not set up to save the government money. We shouldn't be surprised that it doesn't save the government money. If you want to have a competitive bid and see what you could do to lower spending, you've got to have traditional Medicare also part of this program, and you can't force any savings or all savings to have to be returned in the form of greater benefits. But it does show that at least on some of the not very well-defined measures of quality that are mostly process, unfortunately, that these plans can do pretty well, frequently better than traditional Medicare. I think probably the major lesson that I take away from the Medicare Advantage experiences is that you have to be very careful how you design the program so that it can do what you want it to do. And you need to make sure that it occurs on an even playing field in terms of the regulatory burdens, in terms of the quality metrics that are proposed, in terms of the advertising or marketing rules that are in place. For many years, the constraints have only been on Medicare Advantage, and I think in part it reflects this long-held bias that you didn't have to worry so much if it was traditional fee-for-service Medicare, and that reflects, unfortunately, our long-held bias that more is going to be better than less, so we don't have to worry about it if the incentives are to do more. But actually, what we need to worry about is how the patient fares in terms of the medical outcomes and whether or not care is being provided in an efficient and effective way. And we need to have the kind of metrics that will help us see whether or not that's the case. The people running the program, the physicians and hospitals providing services, and the patients who are using that care. And we have done a not very good job in terms of allowing that to happen.
Thank you, Dr. Wilensky.